Welcome. Today we're going to talk about childhood elimination disorders, and these are two: enuresis and encopresis. Enuresis is repeated voiding of urine into a child's clothes or bed, and this voiding may be involuntary or intentional. So these children will urinate on themselves or in bed. This behavior occurs at least twice a week for at least 3 consecutive months in a child who is at least 5 years, and causes clinically significant distress and impairment. We cannot make a diagnosis of enuresis in a child before they are 5 years and above. This is because by 5 years, these children are expected to have developed and achieved dryness. Two types of enuresis exist. One is primary and the other one is secondary. Primary, this child has never achieved dryness until the 5 years, while in secondary, the child has achieved dryness, then they start wetting themselves. And this wetting can occur at night, which we call nocturnal, or during the day, which we call diurnal. What are the causes? Genetics play a big role in that if you find a family member who has a history of enuresis, you tend to find the children having a similar history, especially if it's the male part. Disorders of sleep tend to be one of the causes of enuresis. Blood abnormalities and dysfunction, constipation, bladder infections, things like cystitis. The other part is psychological. Psychological tends to come especially for secondary enuresis in these children who have achieved dryness. Psychological causes include the birth of another child, change of school, fights happening in the family, psychological or physical trauma to these children, divorce. All these affect children, and you find a child who had achieved dryness is starting to wet themselves. And the other biggest part is we don't know what is the cause. How do we investigate this disorder? The first one is a urinalysis. We want to look at the urine to eliminate the infections. We do the ultrasound scan of the abdomen. This helps in looking at the disorders of the functional disorders. Radiographs or uroflowmetry are the other investigations where we're looking at the urine flow. How do we manage this disorder, or how do we treat this disorder? We want to minimize the embarrassment and anxiety that this bedwetting causes. You find a child, they get quite embarrassed if at school they're wetting their beds. If a child is in a boarding school and they're wetting their beds, this tends to embarrass them and causes a lot of anxiety. So one of the things is to make them comfortable, we want family members to come and share their experiences, especially if there's a family member who has a history of enuresis. When they come and share their experience with the child, it makes the child not feel alone during this period. The other thing we want to do is what we call behavior modification or positive reinforcement. We can reward these children for having dry nights. For example, if you have a dry night or if you have dry nights in the week, we can reward these children by a certain token. The other important thing we have to do is a caring parental attitude. We do not have to harass these children when they're bedwetting. We have to be more caring, and we go through this issue with them. As parents, we can take the child to the bathroom before bedtime, and we limit the fluid intake before bedtime. This will help in stopping the bedwetting. The other thing is the alarm therapy. So what happens, we connect an alarm to the children in their panties or in their clothes. And what happens is, because once they start urinating, the liquid completes the circuit and the alarm will go off. When the alarm goes off, you will wake up the child and take them to the toilet to urinate. Pharmacologically, drugs with antidiuretic and anticholinergic effects have been given to help in bedwetting or enuresis. So have antidepressants been used. The other elimination disorder is encopresis, which is involuntary discharge of feces. Most of the times it's a consequence of chronic constipation and resulting overflow incontinence. These children will tend not to want to go to the toilet, and what happens is the stool gets impacted, and once the stool gets impacted, at some point the sphincter muscle will let go and they can't control this. These children present with repeated passage of feces into inappropriate places. This tends to occur once a month for at least 3 months and occurs in children who are at least 4 years. So by 4 years, you expected a child to have achieved dryness. They shouldn't be soiling themselves. So you cannot make a diagnosis of encopresis in a 2-year-old child or 3-year-old child. What are the causes? Like I've already talked about, it's usually a consequence of chronic constipation with overflow incontinence. We investigate it through abdominal x-rays and anorectal manometry. This one shows the child's defecation dynamics. How do we treat it? The first step is to demystify and educate the parents, the caregivers, and the children about the disorder, how to work through it, and how to manage it. The other thing we do is chronic disinfection. This can actually be physical. You tend to disinfect the feces. We can also use laxatives, and this will help them to avoid the constipation. Toilet training is another important part where we are regularly going to set time for these children to go to the toilet. Once the time has been set and they get to know the time, it becomes a routine and they won't soil themselves. The other thing is to give them rewards. If they have times or days they go without soiling themselves, you reward them with a token of appreciation. Pharmacologically, we tend to give them oral cathartics that help in the disinfection. We use enema preparations, laxatives as well, and high fiber diet that is encouraged. In the next episode, we shall talk about mental disorders in the adult. Thank you for watching and prioritizing your mental health.